Good afternoon, everybody. I know people are still going to be filtering in, but we thought we'd get started since we have a pretty large program today. I just have to apologize up front. I sound even more like Kermit the Frog than I normally do. I'm just getting over a cold, and we'll see how long my voice holds up. Welcome to this 5th annual Food is Medicine Symposium. My name is Robert Greenwald. I'm a clinical professor of law here at the law school and the faculty director of the law school's Center for Health Law and Policy Innovation. The center houses both the law school's health and food law clinics, and so, as you might guess, food is medicine is a perfect fit for us. Nothing brings our teams closer together than work at the intersection of food and health. To start, I just want to acknowledge a few people. I want to acknowledge Katie Garfield from the health team and Nicole Nicoletti from the food team at the Center for Health Law and Policy Innovation over there, and also Emily Leib, who's the deputy director of the Center for Health Law and Policy Innovation and the faculty director of the Food Law Clinic. We have really long titles here at Harvard. So thank you so much for all of your work in planning this event. But I also want to recognize, of course, community servings, and in particular, David Waters and Jean Terranova over here for co-hosting the event. They have, of course, played a leading role in planning this event and then in all things food is medicine with us. It's a pleasure to partner with them. So it's truly awesome to have so many people here today. I mean, this event is rapidly growing. It's getting to a point where we may run out of a room big enough, even at Harvard Law School, to accommodate as many people as want to enroll. I think we had to close the waiting list like 3 weeks beforehand just because so many people wanted to be here. So that's fantastic. So tonight's event really is about coming here together at Harvard Law School each year around the same date, which is really very near World Food Day, to reflect on our shared accomplishments in expanding the reach of food as medicine, and then also to describe our goals moving forward to address affordable and healthy access to food. So again, thank you so much, all of you, for coming and for expressing your interest in this important issue. So as a reminder to those of you who have been here before, and as an introduction to those of you who are here for the first time, this phrase, food is medicine, can mean different things to different people. So I want to spend just a few minutes telling you what we mean when we use these words, using this graph here to illustrate that there's a continuum of need for food as medicine. At the top of the pyramid is the low-hanging fruit, if you will, of the food as medicine interventions based on severity of healthcare need, with medically tailored meals delivered to people who are unable to shop or cook for themselves or their family, but whose health condition could be treated or managed more effectively through the provision of medically tailored meals. Here, we're often talking about the 5% of people on Medicaid who are often the sickest and the hardest to reach, the 5% who often consume 40 to 50% of Medicaid dollars, who could greatly benefit from an intervention of 3 healthy, medically delivered, home-delivered meals each day. So in this context, a growing body of research demonstrates that medically tailored meals meets the triple aim of health reforms: improving individual health outcomes, supporting population health efforts, and reducing healthcare costs, in large part driven by reductions in preventable hospitalizations and the length even of hospital stays. So in fact, at this moment of time, when rising healthcare costs is such a major concern in our society, the research really shows that it is only the short-sightedness of our healthcare system that such interventions as meals, home-delivered meals, is not fully integrated as a medical intervention into our healthcare system. Here, food as medicine shouldn't have to be funded out of grants or private donations or even discretionary healthcare programs. Instead, it should be reimbursed as the medical service that it is through public and private health insurance costs. Now, moving down the pyramid, there's a growing evidence of the effectiveness of the provision of medically tailored food as compared to meals. This is for those who are able to shop or cook for themselves, but who are living with or at risk for a defined chronic or serious illness and cannot readily access or afford healthy, medically tailored food. So here I'm combining the second and third tier of the pyramid, those who are living with and those who are at risk for chronic and serious illness. For these populations, the most appropriate intervention may be a box of healthy, medically tailored groceries with recipes, perhaps also including some basic screening, nutritional counseling, even a cooking class, all provided or in coordination with a food bank or a food pantry. Again, the good news is the effectiveness of the use of medically tailored food in improving health outcomes and in reducing costs is also increasingly supported by research. In fact, studies in this area have demonstrated the positive impact of medically tailored food in so many different contexts and with so many different health conditions that we now have a host of new research that's underway in this area of addressing the food is medicine pyramid. So we're going to hear more about some of those results and the results of those efforts during tonight's symposium. And again, most importantly, I'm just going to keep stressing the same point. Our work in these top tiers of the food is medicine pyramid is largely about securing appropriate healthcare resources through health insurance so that we can scale up and replicate innovative interventions that provide healthy food and healthy meals to people in need. So now finally moving down to the bottom of the pyramid, we also strongly believe that there's a foundational truth that all people deserve access to affordable, healthy food. Food is medicine includes making sure that our safety net food and nutrition programs, such as Meals on Wheels, SNAP, food banks, food pantries, are more robust. We know that food insecurity increases the risk of chronic disease, and that being hungry or food insecure is also associated with having higher healthcare costs. We need these programs, and we need to ensure that they have sufficient resources to be able to provide food that is nutritious and healthy. That is also what Food is Medicine is about. So tonight, we're pleased to present a program that reflects important parts of this food is medicine continuum. It showcases some true innovators, game changers, if you will, in the fields of food is medicine, who are showing the mainstream healthcare industry why it's necessary to transform business as usual and to integrate food into our healthcare system. So we're going to open this session today with a practical look at the nuts and bolts of how food and healthcare providers are working together to develop innovative partnerships, to use food as medicine to address food insecurity and diet-related chronic conditions. Then we have the great pleasure of honoring one of the greatest national champions of the food as medicine movement, one of our congressmen here in Massachusetts, Jim McGovern. Next, we'll hear from a panel of medically tailored meal providers and their research partners about the cutting-edge work that they're doing to build further evidence. I mean, we have a strong evidence base already. Over the past 5 years, we have made incredible progress in terms of what we can prove and document about meeting this triple aim of improving health outcomes as well as reducing costs. And they're working to build on that body of evidence, so it's basically incontrovertible. So we're going to hear more about that. And last but certainly not least, we're going to close the evening with a keynote from our friend and colleague Kevin Cranston, the Assistant Commissioner of the Massachusetts Department of Public Health. And Kevin's going to really provide us with a short history lesson, telling us a little bit about the government support for food as medicine through the Ryan White program, which is in many ways what really created the idea of a food as medicine intervention and the idea that governments could actually be involved and engaged in supporting the provision of healthy food to its people. So very excited to have Kevin here with us today. So we hope that you'll be as excited about these presentations as we are. Then one final comment I want to make. As I said at the beginning, today is really about looking back in some ways at what we've accomplished over this past year, but it's also looking at where we're going in terms of moving forward. And just to be clear, this event is not a one-off event for us, and there are many other plans that we have moving forward, but I want to share one in particular. So thanks to the generous support of the Blue Cross Blue Shield Foundation of Massachusetts, or of Massachusetts Foundation, we'll be partnering with Community Servings over the next year to systemically examine the need for and access to food as medicine interventions through a new Massachusetts Food as Medicine State Plan initiative. As part of this initiative, we're going to be surveying insurers, healthcare providers, community-based providers, advocates, consumers, to really understand what food as medicine interventions look like across this state. We're going to be holding regional listening sessions to hear about best practices, challenges that continue to exist, and again, as much as possible, really hear from voices of people that need the services that food as medicine should be providing. And so this effort is going to require broad-based support from all of you here and others. So we're really looking forward to working with you. And really, this is a lot about, this will be the first state plan on food as medicine across this country, and really help to prepare us to continue in this leadership role. We have colleagues here from California. They are lucky enough to have had, as part of their state legislature, an appropriation that was signed by the governor of millions of dollars to support food as medicine. Now they're scrambling to put a plan together, right, and how to use the funds. We're doing it the other way around. We're going to try to have a plan first as we work to get the money from the state legislature so there's money to support food as medicine interventions across our state. So again, just thank you for being here. I hope you enjoy the presentations we have. And now I have the pleasure of turning it over to Emily Broad-Leib, who's going to moderate our first panel on hunger as a health issue. Thank you.
It's official. So let me echo Robert in welcoming everyone here. We're so excited. This is sort of a highlight for us every year, not only because it's a great chance to show the partnership with our partners at Community Servings, which has been a really fruitful and long-standing partnership, but also, as Robert said, across the two programs that we work on every day in our own center, looking at health and food. And so this has been a real bridge between those two pieces and a great chance to bring together an audience of people who really are coming from these two worlds, and there's so much chance to work together. And I'm also excited because the panel I get to moderate is really about these partnerships, bridging this gap between the community food providers and then the healthcare arena, and figuring out ways that we can innovate to really get services and food to people who need it. So we're going to hear from two different speakers, one coming from the food side, reaching out to healthcare, and the other coming from the healthcare side, reaching out to food, to hear a little bit about what they do. So before I turn it over to our speakers, we have a very short panel. I want to just tell you a little bit about them. They're both really impressive in everything that they do. So to my right is Dr. Kathryn Brodowski, who's the Senior Director of Health and Research at the Greater Boston Food Bank. And she's actually the first to hold this position, and is responsible for creating partnerships between the food bank and local hospitals, community health centers, and she'll be talking a lot about this hard work to make those partnerships and really bridge the gap between hunger and health. So Dr. Brodowski is also assistant professor in the Department of Family Medicine and Community Health at UMass Medical School, and also on the Massachusetts Medical Society's Committee on Nutrition and Physical Activity. So in a moment, Kathryn is going to start us off, but let me first also introduce our other speaker, Sue Joss, who is the CEO of the Brockton Neighborhood Health Center. So we're excited to welcome Sue back. She was here a couple years ago telling us about a very new partnership that they had with Vicente's grocery store, which now is much more mature, so we're going to get to hear an update on that. So Sue's led the Brockton Neighborhood Health Center. She's been the CEO since its inception in 1994 and has led it through growth to 3 sites, serving more than 33,000 patients annually and providing more than 200,000 annual visits. She's the current chair of the Massachusetts League of Community Health Centers and is the immediate past chair of the Metro South Chamber of Commerce, and is also a founding executive board member of the Community Care Collaborative, which is an innovative community health center-led ACO in Massachusetts. So we're going to hear first from Kathryn. You want to head over there? Okay.
Indeed.
Perfect. Thank you.
Great. So good afternoon, everybody, and thank you so much for the warm introduction, Emily. I really appreciate it. My name is Dr. Kathryn Brodowski. I'm the Senior Director of Health and Research at the Greater Boston Food Bank. First of all, Can you guys in the back hear me okay? I just want to make sure. Great, I'm hearing nods. I'm a preventive medicine physician, and I always feel like our specialty needs a little bit more PR. You may have heard of a cardiologist, you may have heard of an internist. A preventive medicine specialist is a person or a physician who really thinks about whole communities, whole populations, and what can we do to intervene and to improve the health of these large populations. My passion in particular is both nutrition and food insecurity, and I couldn't have found a better home than the Greater Boston Food Bank. I'm delighted to be here today. Specifically, I was asked to speak a little bit about our programs. We handle both programs and research, so I'm going to tell you a little bit about what we've been doing in the program realm and also lessons learned. But first, I have to introduce you to someone who's much more important than myself, which is Juan. He is one of our amazing truck drivers at the Greater Boston Food Bank. And why I want to show you this slide is a little bit of Food Banking 101. For many of you, it may be your first time hearing about a food bank, and what is a food bank in comparison to a food pantry? So the Greater Boston Food Bank actually serves all this area you can see up here on the map, eastern Massachusetts. We act basically as the food nexus. We have a huge warehouse. You should come see it sometime. And we basically work through a distribution network of more than 500 member agencies, such as local food pantries and soup kitchens. And that's how we get food out to folks in need. We cover 190 cities and towns in eastern Massachusetts. And I always like to take a pause here and just engage with the audience. So bear with me for 1 second. Did I do this correctly? No. Hello? Yes? Great. Okay. So very quickly, to show you what food banking is, I want you all just for a second to think about this bag. It's very important. This is about 3 pounds worth of fresh apples that we have here. I usually do this with 3 or 5 pound bags. So just everybody have that mental image. You can kind of see how much it weighs. All right, I'm going to put that down. How many pounds of food do you think the food bank distributed last year alone? No, not to you, no. Any guess is good, any guess is good. Any guess will work. A million. That is an excellent guess, excellent guess. I want you to go higher. Oh, I heard, oh. 2 million. Higher. 100 million. 100. Okay, so you're getting very excited, sir. Yes. So, okay, I'm going to go back up here. So last year, it was 60 million pounds of food last year alone through our network of distribution partners. I do that exercise to really show you the impact that we can have, the large volume of food that we are talking about. So thank you for indulging me. All right, so back to the regular show. All right. So I was brought on really to connect with the health sector, as I can speak the same language coming from being a physician. And we at GBFB really believe that there is a need for innovative clinical community partnerships that really tackle food insecurity as a social determinant of health. There is a wonderful study done by the Robert Wood Johnson Foundation showing that 85% of physicians surveyed pointed to unmet social needs, such as lack of access to nutritious food, as directly leading to worse health, and that addressing those needs are vital. My main point here tonight is that we do not have to reinvent the wheel. We can very much smartly leverage our resources by drawing upon each other's strengths. In the food bank, we have the food, and we are very excited to partner with our medical community to get it out to the people in need. All right, so I'm going to tell you a little bit of our approach that we have on the program side. We have a 3-pronged approach that we do with community health centers in particular, since they serve so many of the low-income folks who are probably food insecure. We always like to meet folks where they're at, so we offer this as a menu of options. Everybody has different capacity and perspective, so feel free to choose which ones are most applicable to you at the moment. So the first thing that we offer is a free produce mobile market, completely free, fresh fruits and vegetables, usually given out 25 to 30 pounds at a time for an entire household. We do this in the external parking lot of community health centers, as we found our initial model with Boston Medical Center Center was fabulous, but it occurred inside a hospital, and many hospitals cannot devote that prime real estate setting. The other thing that we really are encouraging folks to do is to screen using a quick 2-question tool called the Hunger Vital Sign, which I'll speak to you about in a second. And then lastly, a toolkit. So we want patients not only to be connected to our mobile markets, but also to the local community infrastructure, farmers markets that accept EBT, cooking resources, SNAP, and WIC. This is a little bit about the Hunger Vital Sign. It's a very quick, easy tool to use. The first question really addresses worry among patient households, and the second addresses whether they've actually run out of food. An answer of often or sometimes to either question is a positive screen for food insecurity. So one of the things I was asked to talk about is being practical. What did we learn? We have operationally now 6 community health center produce mobile markets. And the main point I want to get across is to meet folks where they're at. When we started, we had health centers at many different points in this journey with us. Health Center A really said to us, gosh, I really want to focus on the free produce mobile market. That sounds terrific. Screening for them really wasn't for them at that time. They didn't have capacity or the staff infrastructure to implement screening. So they said, you know what, Kathryn, maybe a little bit later. They also had a really robust community health department that was several staff strong, and so they were really able to connect already with the local services without the need of a new toolkit. This turned out to be a wonderful site, very well run. 150 households are served every month with a potential reach of 500 adults, children, and seniors. Now, Health Center B went the complete opposite paradigm. They went gung-ho on all 3 options. And they had a physician with technical expertise, this does not happen every day, that over the weekend was able to adapt their electronic medical record system and incorporate the Hunger Vital Sign. So they were able to implement the Hunger Vital Sign screening in all 4 of their clinics, and they chose medical assistants to really be the point people for that. Positive screens were linked to the ICD-10 code Z59.4. And in the first few months, they had screened over 1,200 patients. And they found 67% of them were screening positive for food insecurity. That is the majority of patients at the health center. It turned out to be a really nice, well-run, large-volume site with 450 households served monthly and a potential reach of more than 1,300 adults, children, and seniors. I'm going to pause here and give you a little clip. Bear with me technically.
5 pounds of fresh fruits and vegetables.
We typically give about 6 to 8 different varieties of produce.
What do we have here?
String beans are right up here pre-bagged for the patients and ready to go. We have some wonderful red beets. Over there, tangerines. And then on the far table, we have some apples.
There was a line out the door an hour before the farmers market opened at the Charles River Community Health Center in Brighton recently. 53-year-old Blanca Gutierrez, who cleans offices part-time, suffers from high blood pressure, seizures, and other health problems. Speaking in Spanish through a translator, she says the free produce has helped her lose weight and make healthier meals for her family.
Con el celery voy a hacer una ensalada.
With the celery, I'm going to make a salad.
El repollo voy a hacer un picado.
With the cabbage, I'm going to cut
Con
it.
chile y
And I'm
limón.
going to make it with lemon and chili.
Gutierrez says the health center market also helps her financially.
Como el dinero hay veces que no
There are
tiene que
weeks that you have to pay your rent.
uno tiene que pagar renta.
There is not enough money left to buy food.
Y entonces esto nos cae como del cielo.
So this comes from heaven.
Helping my patients access food has made me a better doctor.
Dr. Elizabeth Quinn recalls the difficulty she had caring for a patient with uncontrolled diabetes and hypertension.
We were both frustrated. Every visit, I felt like I was talking past him. Why would I adjust medications that he couldn't afford? Why would he keep coming back if I couldn't actually improve his health?
Then, Quinn helped her patient register for the free produce market at the Greater Lawrence Family Health Center, and the patient became a regular, picking up produce monthly.
His blood sugar improved. His blood pressure was under control. For the first time, I finally felt like I was treating his diabetes.
Okay, I'm going to pause there for time and just show you one more slide to be respectful of my colleagues here. All right. I do want to point out that the whole medical community is really learning about screening right now and then connecting to interventions such as free produce mobile markets. And there is a long way to go, and just wanted to share a couple key points for those who are interested in screening. A lot of providers are really just now learning about food insecurity. And so we really want to meet folks where they are at and raise awareness of the issue. We also need to remember that medical staff are doing a lot of things. They are very busy. They wear a lot of hats, and really be respectful of clinical staff time. Screening should, as much as possible, be convenient and tailored to clinic workflow. And it is also a very big lift if we ask folks to screen from 0 days a year to 365 days a year. So just some practical things to keep in mind. And also, you might want to try screening in one clinic at first and then rolling out to others instead of doing all clinics within a health center at once. That's also a big lift, as well as the many different electronic medical record systems out there. We have evolved learning from this, and we do offer now one program where we work with community health centers, loaning out iPad technology as part of a needs assessment to systematically screen in at least one clinic for a period of about 3 weeks, and that gives you a good barometer of the prevalence of the issue. And I'll just highlight a couple here. So we have seen at community health centers thus far that in one case, 59% of those sampled were screening positive for food insecurity, 51% in another, and 57% in the last slide over here. So we're really talking about the majority of patients at community health centers. So as more and more screening starts to happen, we'll start getting a better idea. And in my vision of sustainable future, I would love to see more and more EMRs adapted to incorporate screening and to start using the diagnostic code. But there's a lot of changes going on in our wonderful state that will help encourage this. And I think I will just pause there and leaving on an end note that we are also expanding from programs now to research, and I have some lovely colleagues in the room that are going to be working with us on our research arm. Whereas again, we don't want to reinvent the wheel and become a research institution, but rather reach out to other local institutions in Boston and work with them on research projects that can help show whether we're moving the needle on health and cost outcomes. Thank you so much for your time. I greatly appreciate it.
Thank you, Kathryn. And we'll now hear from Sue.
Thanks. It's great to be back. 2 years ago, I was here right the same month as we were opening our new community health center site, which is co-located adjacent to Vicente's Tropical Supermarket. So wanted to start, this is our main site of the health center now. Wanted to tell you a little bit about how the relationship between the health center and Vicente started. So we are a very rapidly growing community health center. We opened in 1994 in a medical van with our offices in the Sunday school classrooms of St. Patrick's Church. And within a couple months, the same year, Vicente's convenience store opened in a 1,500 square foot convenience store on the south end of Brockton. Both of us became two and possibly the two fastest growing businesses in Brockton for about 20 years. So Vicente's expanded to a fairly large market down on the south side of town, brought in the entire family, so it went from the dad to the dad plus 3 sons and 5 nephews running the business now to the 9 of them. And we grew to our current size of serving 33,000 patients, about 200,000 visits per year. So about 4 years ago, we were running out of space in this main site, and the Vicente's family had been trying already for a couple years to figure out financially how to open a much larger supermarket near where the health center's main site is. So they wanted to go from their 16,000 square foot building to a new one that was about 32,000 square feet. But they were having financial problem with it because they couldn't afford to do it on their own. They needed a partner, and they had been having trouble identifying a partner for years. I also want to point out, this is our patient ethnicity at the health center, and you'll see the large orange color is Cape Verdean patients. So it was natural for us to start working with Vicente's Market because it's the Cape Verdean family, and they specialize not only in Cape Verdean produce and imports, but also Haitian and Portuguese as well. And you'll see the second, the reddish large amount down there is Haitian. So they were serving our patients, we were serving their customers, so it was natural that we got together. And you see the rapid growth of the health center over those years as well. So this is 5 of the 10 Vicente's family. And as we were out of space and they were trying to figure out a financial partner on their site, you would have thought we would have come together and had a plan and incorporated the nutrition piece into it. But what really happened is we were looking all over the community and in some surrounding communities for additional space. And they were working with a developer to try to bring in business partners onto the site with them. We happened to run into them at a prevention and wellness meeting that the community had called to work on a grant together, and they were invited to the meeting. And they came into our group meeting all excited because they had finally found the partner that was going to come into the site with them and help them financially so that they could open the supermarket down our way. This was their partner. So we all had the same groan that you did. And after the meeting, I went up to one of the owners and I said, you know, it's great that you're going to be going ahead with the market, but is there any way we can talk you out of this particular partner? Because we're concerned about the health of our community, and we know that where there's a prevalence of fast food restaurants, diabetes and obesity and a bunch of other bad things start happening in greater frequency. So their response was, well, we've been almost 3 years trying to find a partner. Unless you can find us someone quick, we're going ahead with this. So within 2 weeks, and that's really fast for a community health center to move because we have a community board, but within 2 weeks we said we would do it and agreed to open a site with them. So we are adjacent. We are technically 2 separate buildings, but we have an adjoining wall. This is the site, and you can see on the near side is Brockton Neighborhood Health Center. We opened a 13,000 square foot primary care and nutrition site, and on the far side you can see Vicente's Supermarket. We wanted to, so we finally figured out after we decided to do it that we really had something that we could work with on the nutrition aspect. So we have a teaching kitchen right in the front window of our building. And we have evolved to a program where we now have 3 full-time registered dietitians and 2 part-time and a bunch of community health workers doing cooking classes and shared medical appointments. So we have 2 physicians and 1 nurse practitioner who are now doing shared medical visits with the dietitian, teaching cooking and providing medical care right in the room. And then at the end of each class, the community health workers are taking the patients into Vicente's to teach them how to shop in a more healthy way. So this is some scenes from Vicente's. It was very important to us. They have produce right as we walked in. We helped them with some of the signage. They really cater to their Cape Verdean and Haitian customers in particular with fruits and vegetables that you often can't find easily in other settings. Of course, had some dignitaries visiting us at various times. Fresh fish and an open churrascaria type grill. This is our teaching kitchen, and we have now 3 classes a week and just about to expand to 6. Some of the classes are just the dietitians and some of are the shared medical visits. And they are teaching our patients to cook with more of a plant-based diet, but at the same time respecting their cultures and the flavors that they love. So working with them on substitutions and increasing the proportion of plant-based diet and reducing but not eliminating some of the foods that they aren't willing to give up. This is just some of our scheduling. I just wanted to escape out of here for a second. We have a brief video that actually Vicente's put together Well, let me keep talking while you do it, because I told you my technical skills aren't there. But we've had some evaluation and some initial data from some of these programs, and what we've found is that for some of these programs that we've been doing, we have had anywhere from 70 to 85% of our diabetic patients reduce their A1C over the course of the cooking kitchen programs, and most of them have maintained that level at some time after the course was over. Let me just see if this will start now.
In 2015, Brockton Neighborhood Health Center and Vicente's Market decided to collaborate to make Brockton a healthier place. 7.5% of the population in Massachusetts has diabetes. In Brockton, it's about 10.4%. At the health center, 12% of our adult patients have diabetes. In 2015, we started slowly in October. And in 3 months, we had 10 cooking groups. And we had about 146 patients come through those classes. We offer those classes in any language that is appropriate for our patients. So we have community health workers who also help instruct the classes with the dietitians. In 2016, we were much busier, the demand was higher, and we added a specific class for diabetes. We had 81 different groups in 2016, and we found that 84% of our patients improved their blood sugar. So at Vicente's, the selection of produce is truly unique. It's high quality, but also it's completely varied and it's from around the world. Our patients are thrilled with it because we can have produce from Haiti, from Cape Verde, from South America, and we use the produce in our groups, and people love to shop there because it makes them feel at home. Giving people advice one-on-one is important, but also you have to look at like the bigger issue of nutrition. And so we're able to do that with Vicente's at the grocery store. And that is what's truly unique and we hope very effective as we look down the road and we think about our future collaborations with Vicente's. We have lots of great projects in the years to come. My name is Mary Lynch. I'm a dietitian at Brockton Neighborhood Health Center.
So as I started to mention, we've actually had two major program evaluations happening on what we've been doing. And as Mary told you on the slide, 84% of our patients with diabetes have had their A1Cs, which is the blood sugar level, go down and stay down for a while. This is one of the interventions we did at the supermarket, and we did this in conjunction with the University of New Mexico, which is doing this around the country. So we put in multiple languages floor mats that directed them to the produce section. And then we've also had, through our federal OCS, Office of Community Services grant, they hired a program evaluator, and some of the things that he found in results of their program is that our collaboration with Vicente's did increase the coordination of care between the grocery store and the health center. Oops, I went the wrong way. Sorry about that. Economic development, so we're looking at social determinants of health in a broader way than just nutrition, although nutrition is the focus. Between the two of us at that site, we added almost 200 jobs to that particular location. That had been an abandoned A&P and Star Market that had been closed for more than 20 years. It was where the drug deals were happening in Brockton, drinking. People weren't coming out of their houses. So it really changed that neighborhood in a positive way in addition to what we did with the food. So some things that really made it work for us is really working with the Vicente's family. We had been working with them for years, but really bringing that relationship together in a way that was respectful of us running a health organization and them needing to make a profit. They're a business, and that was one of the factors that really we needed to work through in a thoughtful way. One of the most interesting things, I think, also about what has come out of this is last week, 2 of the Vicente's brothers went to Washington, D.C. for a conference and presented at a conference of the Food Trust, which was sponsored by Pew Charitable Trust. They've really had an evolution in their own thinking. They used to think of themselves as grocers, and they still do, but now they really think of themselves as part of the public health continuum. So to me, that may be the biggest win in the first 2 years of really getting them thinking differently about their customers and our patients. And I would also say their business doubled in size, so it has been a win for them. And some of these efforts to get them to sell more produce is a win for them as well, because the highest profit margin in the market is their produce section. Thank you.
Thank you. That was incredible. So you can see just 2 snapshots of the amazing innovation taking place right here in our state. I know we actually have a lot to do, but I wanted to take a couple questions from the audience in the interest of time. So if people have questions for either Kathryn or Sue before we move on.
I'm not up.
Sue, this is a question for you. I'm curious to what degree you see influence multi-generationally amongst your patients and your larger community due to some of the efforts that you're engaging. To what degree are food preparation, food purchasing, eating habits starting to evolve and pass on down multi-generationally?
So I would say we're relatively early in this. You know, we're 2 years open, and really the first 6 months was organizing. So I'd say it's kind of hard to say. I would say at Vicente's market, one of the big challenges for us was their prepared food section. So we had this younger generation, the 3 sons and 5 nephews of the original founder, who really got excited about being part of the community health continuum, and really were working with us to try to put the healthier foods at eye level and some of the shopping tags that they would put on. The dad continued to run the prepared section, and he just wasn't buying it, and still isn't. So if you go into Vicente's market, you'll see some sections that are very, very healthy, and then you'll see the prepared food section, which is you know, very rice-based, pork fat, you know, all of those types of things that are, you know, really indigenous to some of the cultures that we're serving. So it's been a little bit of a struggle. One of the things that we're planning to do in the next year is a grandparent cooking class, where we're planning to take the grandparents, probably doing a school vacation week, the grandparents and their grandchildren, taking their recipes and modifying them, but trying to maintain the flavors, and then having the grandparent teach their grandchildren the new recipes. So that hasn't happened yet, but it's coming.
One more. Okay, one back.
Hi, thank you all for your presentations. Knowing a little bit about what's going on with food banking and also being aware of Vicente's, I appreciate the fact that you all are doing amazing work, but you're a part of a larger food system, and consumers are not just receiving products from the food bank or just going to Vicente's. How are you all fitting in that larger food system? How are you engaging in the broader set of choices that people are making about food? Thank you.
Yeah, thank you. That's an excellent question. So with what we're doing at community health centers, we can offer whole households free produce, usually 7 to 8 varieties to take home with them. But that doesn't really, you know, they're going to get food from other sources. Part of that toolkit that I mentioned also has information about what's locally available, what are local resources, so SNAP, WIC information, and very importantly, farmers markets that take EBT, and cooking. So I think a lot of that has to do with how-to skills, so how-to cooking skills, also recipes that can be very helpful. You know, if you get a new produce item, you may be looking at, what is this? What do I do with this? So that how-to knowledge is really important, and that's where I think really great relationships in that toolkit. We have a new website called Click and Cook at the Greater Boston Food Bank. Folks can go on if they're unfamiliar with a particular food item or have one or two particular food items in stock at home or they receive from a food pantry, they can click those food items and then it'll give you suggested recipes for how to cook with that at home. But I think it's a larger conversation that evolves more so.
Yeah, I would agree, and I would also say that although the collaboration with Vicentes is a highlight, that what we're really focusing on is educating our patients and our community. So the cooking classes that are our patients and open to the community, we've done some local cable shows, so trying to get the word out. We have now our own recipe collection that we're giving out on plant-based diet. So I think it's all about the education as well and getting that out. We're also, other things that we're doing, we do have a food truck coming every week during the season. We've developed a relationship with the farm at Stonehill College. The local hospital is providing food vouchers, and our community health workers are taking our patients over to the farmers market in season as well. So we're trying to broaden the education beyond just the relationship with the Vicentes, although that is a very key piece.
If I can, I'll add on one more thing. And one more thing we're hoping to do in the future. So we talked a lot about our programs that we're offering here, but we're starting new research projects that will begin, and a lot of it is very collaborative. So one is providing healthy food, but that how-to knowledge skills, we've connected with a number of great organizations. So one of them, Good Measures, does some fantastic work on personalized nutrition coaching that's available for Mass Health Tufts Public Health Plan patients. So really having that one-on-one meeting there where you're at, whether it's on phone, email, internet, and really taking the time to really teach those how-to skills, which is great. Another great resource I'll say too is Cooking Matters.
Great. I would love to actually ask my own questions, and I know a lot of you probably have. We have such a tight schedule tonight, so I hope you'll join me in thanking our speakers. And I'm going to turn over to David to give our first Food is Medicine Advocacy Champion Award, which is very exciting. Thank you again for being here.
How's everybody doing? Thank you. So, on behalf of all the community servings folks, so much for coming today. We're really excited. I have the great pleasure of recognizing Congressman McGovern. Congressman, thank you so much for coming and joining us today. It's such an honor to have you with us for the 5th annual symposium with while it may not totally look it was a sold-out crowd. Community Servings and Harvard Center for Health Law and Policy Innovation are incredibly fortunate to have Congressman Jim McGovern championing our shared work in food as medicine, both locally and nationally. As many of you know, the Congressman is a renowned leader in the anti-hunger movement in the U.S. and abroad, and he has also embraced causes that are critical to our clients: health equity, social justice, and fundamental human rights. Representing the 2nd District of Massachusetts, Congressman McGovern was instrumental in introducing community servings, medically tailored home-delivered meals programs to his critically ill constituents in Worcester, Massachusetts in 2012. He has also supported our work expanding to another city in his district, Leominster, Massachusetts. On the national level, the Congressman has advocated for food as medicine in countless ways, from his End Hunger Now speeches on the House floor to a summit he convened on the topic at a farm in his district that included Leader Nancy Pelosi as his guest, to co-sponsoring a congressional briefing on behalf of the Food as Medicine Coalition in 2016. Congressman, recognizing both your leadership and your generous friendship, we're thrilled to present you with the inaugural 2017 Food as Medicine Advocacy Champion Award. We are tremendously grateful to have your support and your guidance in this important work. Thank you. Recognize that picture?
I do. Yeah. Well, I want to thank David for the kind words. I want to thank all of you for all that you do, and I want to thank the Center for Health Law and Policy Innovation and the Harvard Food Law and Policy Clinic and and obviously community servings for hosting this incredible gathering. But I'm looking at this picture. I delivered the 100,000th meal with David to a woman in Worcester. And I remember it very well because she looked at me and she said, "I haven't seen you in a very long time. Boy, you look old." So I can never, ever forget this wonderful lady. And I'm so happy she's getting good nutrition. Look, we were having this gathering on food as medicine, and we're trying to introduce the topic to my colleagues in Washington as if it was somehow this radical new idea. I mean, food is medicine. When I was growing up, my grandmother used to say to me, "An apple a day keeps the doctor away." I wish she was still alive so I could tell her that she was right. I have spent a great deal of time in Congress focused on the issue of food insecurity and hunger. I think it is a tragedy that in the richest country in the history of the world, there are 42 million Americans who don't have enough to eat. And I believe that hunger, like so many other issues, is a political problem. I mean, we have the food, we have the know-how, we have the infrastructure. What we lack is the political will. And at some point, we're going to get the political will, and we're going to solve this issue. But what I've learned in my work on hunger is that the health impacts are particularly devastating. People who don't have access to food end up, with compromised immune systems, end up getting sicker easier. Kids who don't eat can't concentrate their brains on schoolwork. And then if we give people too much of bad food, they get other issues like we're referenced in the previous presentations: diabetes, heart disease, high blood pressure, and so on. And one of the things that I've also learned is the healing power of food, and that's why I'm such a big fan of community servings. That people who have significant illnesses, who go to hospitals, oftentimes get discharged and are just assumed that they can take care of themselves when they go home. And even if they had a bag full of groceries, they wouldn't have the energy to actually prepare a meal. And so oftentimes they account for a large number of readmissions. And hospitals get penalized for readmissions. And insurance companies have to pay more when people get readmitted. So it seems to me that medically tailored meals like the ones that Community Servings deals with, that smell and taste like your grandmother's cooking, if I got the advertisement right, are things that we ought to be talking about in Washington and finding ways to cover them. I had written to CMS, I think it was a year ago, asking them to issue guidance to states on how meals may be covered in Medicaid under existing coverage authorities. And I've urged them to broaden the scope of coverage for meals in Medicare to all Medicare beneficiaries who live at home, and encourage the inclusion of therapeutic meals in relevant demonstration projects and innovation models. Unfortunately, CMS got back to us and basically said, well, we think that's out of our jurisdiction. I'm not sure I agree with that, but if it indeed is, then we ought to be talking about legislation to expand coverage for medically tailored meals. We ought to be talking about ways to expand coverage, so the doctors can write out food prescriptions. And it just boggles my mind that it's okay. They can write out prescriptions for pharmaceuticals that cost gazillion dollars a year, but sometimes what is most important is a healthy, nutritious meal. And I support all the work that the community health centers are doing, and the Boston Food Bank and other food banks are doing. I mean, it's incredible. When President Obama was president, I tried unsuccessfully to get the White House to put together a summit, a White House conference on food, nutrition, and hunger, in which I thought we could kind of weave together everything, because there are, just like in the examples we just saw, I mean, there are best practices. There are things that are successful, but not every community knows about the success that some of us are having in Massachusetts. How do we expand that? And I thought, a White House conference, with the bully pulpit of the White House and the gravitas of the White House would, we could figure out a way to deal with the issue of food insecurity and hunger and health, from beginning to end. Unfortunately, it never rose to the level that of urgency. I mean, there were so many other things happening, but I regret that. And unfortunately now, I wouldn't even dare suggest that this White House do a White House conference on food, nutrition, and hunger. But I'll just say one other thing. I mean, we need to solve this problem, and we're going to put together a working group in Congress. I co-chair the House Hunger Caucus. We're going to do a working group on food as medicine, and to try to again figure out, you know, what are the concrete steps that we in Congress can take to be wind at the backs of so many of you who are doing innovative things. We should do it because it's the right thing to do for our citizens. That's a way to keep people healthy. We should also do it because it saves money. You know, if I could get you on a balanced, nutritious diet, if I can get you access to medically tailored, nutritious foods, you stay healthier. It's that simple. And we need to find a way to integrate nutrition education in our schools at the earliest age. You know, it's hard to change habits when you get older. It's a lot easier to get people when they're young. You know, a few years ago, I went to a school in Worcester where kids had high absences, mostly health-related. So they decided to put a health clinic in the school. And in any event, in the course of doing that, the teachers, you know, were very involved in it as well. They decided to kind of integrate nutrition lessons in science and math. You know, one of the lessons was, you know, bring to school the drink that you drink most at home with your meals. And everybody brought in a Coke, right? They poured it out, and then they had a big barrel of sand, and they were asked to pour the amount of sand in the bottle or can that equaled the amount of sugar. And it was a huge amount. And I asked this little boy, I said, "What did you learn?" He said, "I learned that having a Coke all the time is not good for me. Too much sugar is bad for me, and that's not a good thing." And I said, "Well, that's a good lesson." And then he said, "I'm going to tell my mother that too." And it occurred to me that, you know, these kids can be our teachers. Believe me, as a father of you know, my kids are now older now, but growing up, I mean, there were days when, you know, just to get them off my back, I'd say, "Here, have a box of candy bars, whatever you want." But if my kids were asking for carrots or apples or water, I mean, you know, I would have gladly given it to them without a guilty conscience. So the point of the matter is there's a lot of stuff that we need to knit together. We need to figure out concrete policy initiatives that we could advance on the federal level, and I think on the state level as well. I'll just leave you with one other story. I'm on the Agriculture Committee, and I do farm tours every year. We just recently did one, and we visited a farmer's market that was involved in this HIP program here in Massachusetts, which is a great program. People get a bigger bang for their SNAP dollars when they buy fresh produce at farmers markets. And the beneficiaries came to this meeting, and they were so excited, and they were so grateful because they could purchase more of what they knew was good for them and their families. And they were asking for new recipes. They were trying to figure out, you know, how do we even be even more creative. But then the other benefit was the farmers who were making money off of this and who said, "Gee, you know, I mean, we want to be part of this because one, it's a good cause, but it also helps us as well." You know, the average food stamp benefit, in case people don't know, is about $1.40 per person per meal. You know, what we ought to be doing in this farm bill is we ought to be raising that number. You know, you can't even buy a coffee for $1.40. That's why people are at food banks. And that's why people are relying on food that isn't very, very good for you. So anyway, I say all of this to simply say to you, I want to be wind at your back. And I think maybe here in Massachusetts, you know, we can develop a holistic model. And, you know, I see Kevin Cranston is here and others, but maybe we develop a holistic model that could be a model for the rest of this country. I mean, hospitals have a role, community health centers have a role, schools have a role, grocery stores have a role. I mean, you know, all of us have some responsibility here. It isn't just the hospitals. It isn't just, community health centers. Everyone has to have an assignment here, and it has to we have to raise the issue to even a higher level than it is right now. And I think it's all doable. Like I said, this is something that should defy politics and partisanship. It makes so much sense, and everybody who's involved, especially in the healthcare arena. I mean, from patients to insurance companies to doctors to you name hospitals, everybody has. This is a win-win-win for everybody. And so I look forward to going with David to deliver the 200,000th meal. And I'm sure because the food is so good that this lady will still be around for that. And she can tell me how much older I got. But I feel strongly about this. And I think that we all need to push harder because I think this is the time. And so whatever I can do to be helpful to everybody here, I want to be on your side. But thank you for this honor, and I appreciate you having me here today.
Here's a bag. Thank you. One of our bags.
Yep.
So hello, my name is Katie Garfield, and I'm a staff attorney here at the Center for Health Law and Policy Innovation, where I work on many of our food as medicine initiatives, and have had the pleasure of working with pretty much everyone on this panel here today. And so our second panel, as I mentioned, is really going to be about the evolving research, specifically into the impact of medically tailored meals. As you all know, developing high-quality research on the impact of food as medicine interventions is really critical to advancing this field. It's really what forms the basis of some of these partnerships between the healthcare system and community-based food providers. By showing that these interventions really do have a significant impact on patient health outcomes, costs, and experience, researchers are making the case that food is medicine, and therefore that it should be accepted as a medical intervention, and as we said at the start, really supported and embraced by the healthcare community and supported by healthcare dollars. So tonight I'm really excited to have a number of organizations and researchers that are directly involved at the cutting edge of this research. And not only that, but who are actually taking this research and using it to drive real change, both at the state and national level. So you have all of their full bios in your program here tonight, but I'm just going to introduce each of them very briefly here at the start. So first, you're going to hear from David Waters, CEO of our amazing neighbor and co-host, Community Servings. David has been involved with Community Servings really since its founding and has been its CEO since 1999. David is a leading member of our National Food is Medicine Coalition and has been working with researchers such as Dr. Seth Berkowitz for a number of years to really move the ball forward on creating high-quality research on the impact of these interventions. And then next, you'll hear from Karen Pearl, who is the president and CEO of God's Love We Deliver, another medically tailored meals provider in New York City. Karen has led God's Love for over 10 years, and in that time has really worked to make sure that medically tailored meals are incorporated into New York's evolving healthcare landscape, including through such programs as the Managed Long-Term Care Systems and the Delivery System Reform Incentive Payment Model. Karen is also the convener and fearless leader of the Food is Medicine Coalition, making her a driving force in the Food is Medicine movement, not only in her home state of New York, but across the nation. And finally, you will hear from Mark Ryle, CEO of Project Open Hand, a medically tailored meal provider in San Francisco, and his research partner, Dr. Kartika Palar of the University of California, San Francisco School of Medicine. As Mark notes in his bio, his grandmother describes him as a social worker with a head for business. I just wanted to call out that line because I think it just really, it could be used for anyone up here on this stage today, and I just really loved it. And we are particularly excited to have Mark and Dr. Palar here tonight, as they will have the opportunity to tell us about the amazing new opportunity that the research they've been doing has created in California. So the first real widespread medically tailored meal pilot in a Medicaid program in the United States. So without further ado, I'm now going to turn things over to David Waters to kick off the panel.
Thank you, Katie, and thank you again to everyone joining us today. I just wanted to start out by explaining to you one more time what we mean when we say medically tailored meals. If you think of the pyramid that Robert gave you, if I said to you, each of you is diabetic, and you were to go to the grocery store today, and you had to think of what you could eat as a diabetic, you'd probably be pretty taxed. But if I said you're also controlling for potassium because your diabetes has led to kidney failure and a renal diet, you'd be even more taxed. But if it had caused you to have a stroke, you'd be on a blood thinner, and you'd also need to control for vitamin K. I didn't even know there was a vitamin K.
Yeah.
For those of us in the room who I presume have had a fair number of blessings in our lives, it would probably be one of the harder things we would do. You know, even those of us who are adamant foodies, would you know where the glucose, potassium, and vitamin K is in your food? But now if you strip away the privileges, like the clients of Community Servings or God's Love or Project Open Hand or many of our colleagues, here in Boston, 94% of our patients are living below poverty. So they don't have money, they don't have food in their cupboard, in many cases they don't have a roof over their head. But if they also don't speak English or don't know how to read or weren't raised in a culture to self-advocate, and your doctor or your dietitian or your care manager says, please manage your potassium, your glucose, and your vitamin K, we are setting them up to fail. It's almost impossible, and yet that's what health outcomes are based on, that's what healthcare costs, that's what rehospitalization rates are based on, it's what medication adherence is based on. That's the challenge we face. And so the beauty of providing medically tailored meals is that as a healthcare intervention, not just as an anti-hunger, we can immediately address that with great caring and beautiful food. Community Servings, as Katie mentioned, has been around for 27 years. We provide medically tailored meals and nutrition services throughout Massachusetts, stretching as far out as Worcester, up to Lawrence and Lowell, down to Brockton, and as of next month, into northern Rhode Island. What our nutrition intervention is the opportunity to offer our patients lunch, dinner, and a snack 5 days a week, delivered once a week, for them, one other adult caregiver, and any children in the household. The first challenge is to get them to eat when they have no appetite. So if we bring them what I call my high school cafeteria food, they're not going to eat it. So all of our food is made from scratch in our kitchen using local produce, homemade soup stocks, no soup bases, no canned foods, herbs that we grow on our property, controlling for sodium, controlling for preservatives, and culturally appropriate for the communities we serve. But equally important, or even more in this context, we have the ability to offer 15 different medical diets. So all the diets that I mentioned, plus 12 more, Community Servings Kitchen is able to do, but we're also able to cross-prescribe diets. So our patients could be, indeed, renal diabetic, controlling low vitamin K, and we could still do it. Along with that, we're offering wraparound services of nutrition counseling, nutrition education, nausea care packages, and it's something we've been doing for 27 years. But in the last couple of years, the struggle for programs like ours is that they've primarily been funded through government programs for HIV, most of our roots are in the HIV world, or through charity. But here in Massachusetts, or even in New England, community servings is one of only 2 medically tailored meals programs. There's one in New Haven, and there's one here in Massachusetts. Together, we can't begin to address the need in the 6 New England states if all we're doing is looking for charity and philanthropy. So about 4 years ago, we set out to try and convince the healthcare world that really what we were doing was not just anti-hunger work, but really healthcare. And with that, we recognize that the healthcare world has the best of intentions to do exactly what we want them to do. They have the same value system we do, but they also have to look at cost-driven models. And so for us, it became, how do we embrace that level of research that they need to make the argument that we all in this room know intuitively? If you feed a sick person, their medications are going to be better absorbed, their healing is going to be faster, it's dignity, it's improvement all across the health spectrum. So we dipped our toe into research. And so sort of setting up for my colleagues here, I just want to give you a quick sense of how a small human service community-based organization jumps into research. For us, it started with surveying our clients and their children. We knew, in this case, we knew that children, we had a hunch, weren't eating the adult food we were delivering to them. We had no way to do research, so we sent pictograms of our meals home with the families and said to the children, please color in which ones you ate. It's pretty soft data, but it told us as a first step that kids weren't eating adult food. They don't necessarily want, my son doesn't necessarily want the food that I want as a 7-year-old. From there, we went obviously to client satisfaction surveys. But one of the things you learn quickly in our world is that patients who are receiving something as primal as food that they desperately need are scared to tell you anything like the truth if you might take it away from them. So they're going to tell you exactly what you want to hear. Yes, they love the food. Yes, the service is great. Yes, they eat the rutabagas and turnips. So that also wasn't necessarily the best answer. So from there, we added onto those surveys, working with our partners, we added weight goals and stress measurements and energy level and food security. But still, we knew that these were relatively soft data. So we started talking to our referral partners and asking them for the experience. 96% said we were improving their clients' health. 65% said we were decreasing hospitalizations. 94% said we were giving access to healthy food. Great news, but still not measurable in the way that a business person within a hospital or a Medicaid system necessarily needs to know to make an investment. So we were lucky enough to meet Dr. Seth Berkowitz here at MGH and have launched 3 research projects that I'm just going to touch on briefly because they're tremendously exciting. The first is funded by Blue Cross and BNY Mellon, and it's looking at patients with out-of-control diabetes, an A1C greater than 8, who were also food insecure. The challenge for MGH was they knew exactly who had an A1C level greater than 8. They had no idea who was food insecure. So it took almost a year to call 4,000 potential patients, all of who had an A1C greater than 8, to see if they were also food insecure. The challenge with the study is that it requires them to keep a food journal, to make regular visits to the hospital for various testing on A1C and blood levels, et cetera, BMI. And so it's a hard way to recruit people. Feeding studies are a very intimate way to do research. But what we found was we were measuring for the healthy eating index. 5-point improvement would mean significant improvements in health. In our program, we saw a 15-point improvement. Most excitingly is our ARP and Commonwealth Care Alliance evaluation project, where we have a contract to feed patients who are dually eligible, meaning they're both on Medicare and Medicaid. And we were able to look at the claims data of 133 patients that we fed in partnership with, funded by ARP, in partnership with MGH and the Commonwealth Care Alliance to get right into their claims data. And what we saw was across-the-board reductions in inpatient admissions, ED visits, and emergency transportation events but also significantly, statistically significant reductions in healthcare costs. This is out for publication right now. We have the numbers. I'm just not allowed to say them today. But it's tremendously exciting, and whisper to me in the hallway, I'll tell you the number. But really exciting. And building on that was a very exciting grant from Robert Wood Johnson Foundation, which is doing the same thing on a much larger scale. We're looking at 2,000 patients Community Servings has fed over the last 5 years. And with a partnership with MGH and Kevin Cranston and the Department of Public Health, we're able to get into Massachusetts all-payer claims database, which has all of our claims data, and match it up with our clients that we fed and looking at their cost data versus people we didn't feed for the same things we saw in the CCA study. But again, that was 133 patients. This will be 8,000 patients. It's a 30-month study. We're tremendously excited. We are the only non-university, non-hospital to ever receive this funding from Robert Wood Johnson. So we're really exciting. And about a year from now, we should be back to share those notes with you. And then, as Robert said, we are working in partnership with CHILPI, the Center for Health Law and Policy Innovation, on a statewide plan that we just kicked off today.
And then just a question. I'll just use the arrow key, right? Yes. Okay, great.
Good afternoon, everyone. I am Karen Pearl, President and CEO at God's Love We Deliver in New York City. And it's really an honor to be here today to talk with all of you, of course, but also to be with our friends and colleagues from the Center for Health Law and Policy Innovation here at Harvard, as well as our friends and colleagues at Community Servings, and of course, at Project Open Hand in San Francisco as well. So at God's Love We Deliver, we say food is love and food is medicine. Our chef reminds me to say every time, but it doesn't have to taste like medicine. So I thank him for that. And we were approached by physicians at NYU Langone Medical Center from the Department of Oncology, probably now about 2 years ago, to talk about doing a study together that I'm going to share with you. And that study was really looking at the role of food and nutrition as an effective arm in palliative care for people who were living with end-stage cancers. Before I tell you about the actual study, let me tell you a little bit about God's Love and why they approached us. So we are a medically tailored meal provider in New York City. We've been at this since 1985, which is a long time. And we are also, like Community Servings here in Boston, we're kind of the only game in town if you want to study medically tailored meals. We have 7 registered dietitians on staff, and we do many diet modifications, much as David described. Our clients are all able to take advantage of unlimited nutrition counseling. We actually find that our clients living with cancer are the heaviest users of that service because their lives change so much, from diagnosis to surgery to radiation to then perhaps just getting better and better. Their dietary needs change. They also tend to be much more active, ironically, on the internet, and they call with questions all the time because all the information is completely confusing to them. We serve about 7,000 people a year, 1.7 million medically tailored meals to clients living in all 5 boroughs, as well as Westchester and Nassau, which are surrounding communities, and parts of New Jersey. And we have 30 healthcare contracts with providers who are doing managed long-term care, which is care for people who really are having trouble staying in their homes but would prefer to be in their homes than nursing homes or long-term care facilities. We're involved in a number of research studies, this one being in process. And then we do a lot of policy work locally and in the state because New York State is, like Massachusetts, very interested in healthcare innovation. And people are beginning to wake up to the social determinants of health, which is why NYU Langone approached us. And then obviously on our national Food is Medicine Coalition, which I share with my colleagues here today. one of the things we learned is in trying to do all the policy work that we do, because ultimately the research and the practice should go to good policy and changes in policy. And one of the real impediments to that is that people say, well, yeah, I know that study done in Massachusetts or California or Philadelphia, or it doesn't matter where, but I want you to give me research locally, and I want you to do it on the population that I care about. So you can prove in 100 studies that food really makes a difference, nutrition really makes a difference, but people keep wanting to zone in on their population. And that's what happened for us with NYU. So this is the study. The purpose is to evaluate quality of life improvement from home-delivered medically tailored meals. That's what the HDMTM is. In metastatic lung and non-colorectal GI cancer patients who are at the end of their life, at late stage. The purpose was to look at the quality of life measures at the very beginning, before any intervention of medically tailored meals, and then at every 12-week period until the person passes away. Also to look at other nutritional status measures, height, weight, a variety of other things, and some other socioeconomic measures like food insecurity and financial toxicity, but also to look at the cost measures of healthcare utilization and cost effectiveness of medically tailored meals. And I just want to point out that Robert said in his earlier comments that the triple aim of healthcare was better health outcomes, lower costs, and improve patient satisfaction or quality of life. It is the least cared about of the three dimensions, and I really give applause to our colleagues at NYU Langone for recognizing that that really matters to the patient. Obviously, we all care about healthcare costs in a bigger policy way, but zeroing in on healthcare, on quality of life, just keeps being forgotten. So they came to us to say, we want to look at the social determinants of health. We've picked medically tailored meals because we think it really matters. Because some of this earlier research, malnutrition in cancer is highly prevalent. About 85% of people suffer from malnutrition as well as their cancer. And it disproportionately burdens the very cancers that this study is looking at, lung, GI, in advanced stage. Also, everyone has studied repeatedly that malnourished patients have impaired chemotherapy responses, shorter survival, longer hospitalizations, poorer quality of life, everything that they want to turn around. And they did their homework. They read all the research that says medically tailored meals actually improve all of those factors, but it hasn't been studied in late-stage cancer. And that's what they wanted to look at. So that's how they got to us, based on the research and based on our practice, and then we were going to go forward together. But they were worried about two things. One was whether people at late-stage cancer could actually comply with eating medically tailored meals, and could they tolerate that? So they went into our database, which is pretty extensive, and looked at God's love clients who are in late-stage cancer situations and asked those two very questions, and came up with findings that showed that, in fact, there was excellent compliance and tolerability. And here's just some of that preliminary data. And that is that when they looked at that data, they found that 87% of the people ate more than half of their meals, 91% were able to live more independently, 89% were able to eat more nutritiously, 70% expressed less fatigue, which is pretty remarkable for that population, and 61% said that our meals help meet their cultural needs. So based on that, we went through and developed the protocol that went through the IRB and has been approved. It's a randomized controlled trial of home-delivered medically tailored meals to look at the effect of quality of life, as I said, in the metastatic lung and non-colorectal cancer patients. There are 150 people, there will be 150 people in the study, there are not yet. 75% will get the standard of care, which is all of the medical intervention, including some nutrition information and counseling, but not the food. And so the intervention is ongoing nutrition counseling and education and medically tailored home-delivered meals. So 75 in each group. And they will be looking at what is called the FACT-G survey, which is a quality of life survey. FACT stands for Functional Assessment of Cancer Therapy, and the G is general, means just for cancer, not specific cancers. And that is a collection of 27 different questions looking at physical, social, and family questions, emotional and functional assessment. And I'm happy to share more about that with you. It will be at every 3 months, as I said, until the end of their life. And also looking at, as a secondary analysis, the cost of care, food security, height and weight, and some other measures. So to get this off the ground, there has been a very, very carefully orchestrated dance between NYU Langone and God's Love We Deliver. The physicians identify the people who they think will be good for the study. The nutritionists at the hospital do a brief assessment, explain the study. If people are interested, they then randomize into either standard of care or standard of care plus God's Love. And then those who are in the God's Love group get referred over to us for a more intense nutritional assessment and for the figuring out the right meal for that person. Of all of those diet modifications, what do they really need to benefit the most from the home-delivered meal program? And then, of course, we are in constant contact with them. So progress is underway. The study has started. We have people in our cohort of 75 people. But I will also admit that there have been challenges and there have been issues that have come up that have slowed the progress. The biggest issue is that the principal investigator left NYU to go to a position in Texas, and it has taken us a while to get all of that reorganized, but they are now back on track. And then the other was that we discovered that, or the hospital has shared with us, that 21 meals a week feels like a lot for people at late-stage cancer, even though that's what they need. That's what they need from a nutritional perspective, those calories, those nutrients, those vitamins, but it feels like a lot, and they are working very hard on that. But what we are most excited about is that when we get these results, assuming they turn out the way we think they will, we have the ability to change the standard of care for end-stage cancer, hopefully incorporating medically tailored home-delivered meals for people who need them, who don't have other supports in their home, affecting the quality of life, saving valuable healthcare dollars. And Congressman McGovern said in his remarks that wouldn't it be great if we teach young kids the importance of good food and start with healthy habits early on, and I couldn't agree more. But I think the purpose of this study is to show that that's really true even at the end of our lives, that it's important to have good nutrition, good food, healthy food to sustain us even as we are facing the end of our lives, because that is something that all people deserve from very beginning through the end. So thank you very much.
Do I do the clicker or the either? Okay. Good afternoon. It's very lovely to be here. Thank you so much for the invitation to come all the way from San Francisco to Boston to talk about food as medicine, something very dear to my heart. And I am going to be giving kind of a 30,000-foot view of the research. I think being the researcher on the panel for today, a lot of it's going to be ideas and concepts that many of our speakers have already touched upon, so maybe just from a different perspective. Oh, sorry. Yep. Can everyone hear me? Mm-hmm. Yeah. Okay. Some of it might be a little bit of a review, and some of it might bring some new ideas to the table. So let's get started. Food is medicine. So I wanted to actually have you all humor me for a moment and just think about food and what food is, besides our lunch that we just had. Food is obviously a physiological reality. It's biological, it's chemical. We need it. Too little of it, though, too much, or the wrong kind leads to disease and death, even. But food is also emotional, is mental. It affects our mood. Food is love, food is pain, food is stress, it can be shame, it can be many things. It affects our mental health profoundly. Food is also relationship with our partners, with our friends, with our families. It takes place in a social context. Food is identity. Food is culture. Clearly, behavior affects what we eat, but so does our ability to afford food, where we live, and even the ecological and economic systems, everywhere from the local level to the global level. So when we think about food as medicine, I'm also always thinking about what food is and how it's happening. So what happens when there's not enough food, or where there's inadequate access to food? Food insecurity, which we've been talking about, is defined as the uncertain or limited access to adequate, healthy food. And about 41 million Americans in 2016 lived in food insecure households. There are disparities in food security. As I'm sure is not surprising, Black and Latino households have a much higher prevalence compared to white households in the US. About 40% of individuals below the poverty line are food insecure. But it's important to point out that poverty and food insecurity aren't exactly the same thing, because 60% of those households under the poverty line aren't food insecure. And that's because food is not just income, although it's extremely important. Food is also where we live. It's other forms of access to safety net services. It's social support. It's mobility. So starting to think about the cycle of food security and disease, and hopefully you can kind of read that. Here's one conceptual model developed by my colleague at UCSF, Hilary Seligman, that really shows and traces how food insecurity can lead to constrained dietary options and maladaptive coping strategies during times of food shortage, such as only eating McDonald's or fast food when money is tight. But those strategies can actually last even when food is plentiful again. So there's a dynamic process that happens, and all of this creates stress, weight gain, et cetera, can lead to obesity, hypertension, diabetes. In turn, food insecurity then makes it difficult for people to manage those conditions, leading to poor outcomes. Poor diabetes control, for example, can lead to increased disability, cycling back to food insecurity. Another way to think about food insecurity and the pathways through which it leads to poor health was developed by my colleague, also at UCSF, Sherry Weiser. And this framework really thinks about these three pathways that cause food insecurity to negatively impact health. And those are a nutritional pathway, which I think is the most obvious when we think about food. So either malnourishment or overweight, obesity, but also the mental health pathway is in fact very profound and important. And the behavioral pathway as well. This is things like being able to adhere to medications, to doctors' recommendations. I mean, that those together lead to these poor clinical outcomes. So the data shows us that, in fact, food insecurity is associated with a wide range of poor health outcomes. That first column there gives a rundown, and I'm sure I'm even missing things, because really it is vast. The bulk of research has really focused thus far in the area of HIV and then diabetes. And so in these rows, you can see that kind of across the board, we have a lot of studies at this point showing that it not only increases risk and prevalence of these two conditions, but impairs medication adherence, disease self-management, leads to more depression, distress, leads to worse clinical outcomes measured by various biomarkers important for each of these conditions, and increases healthcare utilization, emergency department visits, and hospitalizations. And again, we know that it increases healthcare costs. So then, thinking about food as medicine. This is a very simplistic Venn diagram I drew 3 days ago, just while I was trying to kind of describe this space. As I was thinking about it, when we think about food as medicine in chronic illness, I think it's important to think about these overlapping needs that individuals are faced with a lot of the time. They have their medical need, the doctor has told them that they need to eat this, this diet, low-salt diet, perhaps to manage their heart failure. On the other hand, there's a social or economic need often, the inability to afford the food, or being housebound and not able to really go out and access the food that's needed. And medically tailored food and food as medicine is appropriate across this whole space, but I think where I want to focus and talk about today a little more is in the overlapping version where medically appropriate food and nutrition support is kind of addressing this dual need that the population has. So there's 4 studies in this space, and when I say studies, I'm talking about things that have either been published in the peer-reviewed scientific literature or are presented at a conference, and actually the 2 studies that were just discussed are sounds like they're going to be added to this shortly by community servings. So this is just an overview of the design of these studies, but the largest one of them was the diabetes box study that was implemented in food pantries in 3 states that provided 1 to 2 weeks of nutrition for 6 months. The rest of the interventions provided 100% nutrition for various lengths of time. There were 2 studies on diabetes, 1 on heart failure, 2 that dealt with HIV, and you can see that 2 of the studies actually had different health populations in the same study. And so the Food as Medicine study was the pilot study that Project Open Hand and UCSF conducted together, so that's our baby up there. Little pre-post pilot study that saw some really interesting things. So here are the results. So on the right-hand side, the dark orange, those are what I kind of think of as the hard outcomes. Clinical outcomes, healthcare utilization, and healthcare costs. These are kind of the bottom line outcomes that, for health and healthcare. So we do see that these interventions improve diabetes control and heart failure symptom control. Also, healthcare utilization went down, and one study, the MANA study, showed decreased healthcare costs. But in addition, the top 2 studies, we also see benefits across those pathways that I showed you before in the conceptual framework. And so really, and I agree, Karen, when you were talking about quality of life, I was thinking to myself, these are often posited as intermediate outcomes, maybe not as important. I think they're extremely important. Mental health, for example, quality of life, these are, critical to the well-being of the people that we work with. Oh, excuse me. I'm getting over a cold, so my apologies. Because I'm a scientist, I can't just show that slide. I have to also just give a sense of where these results stand statistically. And we're always more conservative than anybody really wants us to be, but it just has to be stated that in the yellow are the areas in which we found what are considered solidly statistically significant effects at a p-value of less than 0.05. The orange are things where it was close to that threshold, but not quite, so under 0.1, but not quite 0.5. They weren't powered to detect effects at that level, and so actually it's very promising that we saw movement in that outcome. So, and just to point out, this is a very exciting field of research, and I think it's really growing. It has its strengths, which are that we see really across the board promising positive results that are consistent across diverse settings. But it also still has weaknesses as a body of evidence. So, in general, what's published at least still has relatively small sample sizes. There's not always a control group. We weren't able to put a control group in our study, for example. And also geographically, I think there's still a need, as somebody else was mentioning, to figure out how this is going to work in a lot of other places. So finally, I want to just, before Mark takes over to talk about the exciting work they're doing, I'm just going to show you 2 quick slides about our ongoing studies in collaboration with Project Open Hand, UCSF, and the San Francisco Department of Public Health. So the first is a randomized controlled trial, CARDS, looking at heart failure patients and outcomes for folks who were recently discharged for heart failure hospitalization. So this is ongoing, 30% enrolled, with a primary outcome of 30-day readmission. The second study is CHEFS, which is the follow-up study for the Food is Medicine pilot that we talked about in the other table. And so this is actually just finished up data collection. We're analyzing the data. This was also an RCT providing medically appropriate food support to 200, almost 200 people living with HIV with a primary outcome of viral load. And I just wanted to leave you again with that last graphic to remind us that, these things, even as scientists, we narrowly test these impacts. We always try to think about the overall context and what's important in terms of food is medicine. And I really applaud the work that all of my colleagues here are doing on the ground, the policymakers. I think that food is medicine, and medicine is more than just healthcare, right? And then that means food is healthcare. And so I think the work that's happening here is just crucial. So I appreciate being involved with it. Thank you so much.
Good evening. My name is Mark Ryle. I'm the CEO at Project Open Hand. We're a San Francisco, you can't, okay, hold on. Better. We're a San Francisco-based agency. We started in '85 along with God's Love, and we serve about 8,600 clients in the Bay Area, San Francisco and Oakland. And I'm sort of the closer on this panel, so I've got to wrap this up with more slides than you want to see, but I'm going to get through them really fast, okay? To follow up on I want to thank Chilpy and Robert and Jean and Sarah and Katie, and I'm sure I'm missing folks, for bringing us here today to talk about this and leading the movement, frankly. On my way over here, I was coming from the hotel, and I was texting my grandmother. She's 101. She likes to text. And told her what I was doing. And I was born on a peanut farm in West Texas, and she's still there. And I told her I was going to this presentation at the Harvard Law School, and so that's a big deal in West Texas. And she asked what for, and I told her it was to talk about why food is a medicine, why it's important. And she sent me the shaking head emoji, and she said, why do you have to prove that? And that's a good point. So my grandmother's been shaking her head for a while. All right, let's get through the slides. So you have, just at this isn't new, sorry y'all, tricked you. You have just at this table, over the last 3 decades, agencies that have provided more than 50 million meals made from scratch to critically ill individuals. I'd say we have thought leaders and experts in the room. And so what we're going to talk a little bit about is how we went from there to the first statewide Medicaid project in the country, in the state with the largest Medicaid population in the country. It's going to be a quick journey, so hang on with me if I can get the slide thing to work. This one here.
Yeah, try that.
Okay. Hold on. Oh, yeah, there we go. All right. So we at Kartika went through some of this. It's hard following a scientist. Went through some of this. And I'm just going to run through real quickly what we've done. So we started out with that small study, the pilot study that Kartika talked about, where we got some really promising but not quite statistically significant information. But it led to the next larger one, which is this large CHEFS study, which is a randomized controlled trial study that actually has concluded, but we're in the data crunching, which takes a very long time, data crunching phase. And one of the things we're learning outside of the actual intervention of the food is, why do clients engage? This actually is more interesting to me right now than the food part, because we need to understand at what critical intervention or inflection point does a client want to engage in their own health and want to do that through food. And sometimes that's about mental health or social circumstance. And as a social worker who is an investment banker, I try to mix the two. But we have to find the right model, right? Or it won't work. So we're trying to understand that, or how to uncover that in clients. And that's what we, more than the other data, I hope we get information around dosage and engagement that way. Okay. And then the study that Kartika spoke about in San Francisco General Hospital, which is a heart failure study, really high utilizers. And really it was the groundwork for the California statewide program, where we're looking at people right as they discharge so they don't fall back into that abyss of chaos and criteria and other circumstances in their homes, which is tough anyway. They leave with food from the hospital. So we'll learn about the impact of that. And we all know that this all works, right? We see some really important reductions in hospitalization and metabolic data. We see really important improvements in psychosocial issues, in abilities to manage life and to re-engage in their community. So we know the science works. So, I have a great slide. So, this all brought us to where I'm closing the deal today. Now, 4 months later, we are the dog that caught the car, to Robert's comment. So we started out with this beautiful idea. We're going to go to the state and we're going to tell them how important this is. And we have all this research data, and it's local, right? To Karen's point, it's local, it's California. And we're law there. And the state said, okay, we'll do that. And we thought, oh my God. So the value in this, so this is the statewide model. It'll conclude in July 2021. It will serve with the $6 million in immediate funding, 1,000 high utilizer Medi-Cal is our Medicaid, Medi-Cal clients. And those are people who are readmitting within 30 days, more than 4 times in a year, or perhaps more acute, all over the state with 45 million people, 13 Medi-Cal users. And the reason we're able to do it is because we have agencies on the ground throughout the state doing this work, all born of this same movement, all born of a movement that addressed critical illness in a time of crisis. So we all came out of this HIV world. We learned how to do this work because Ryan White let us do it. Now we're applying it to a broader population. So we have an agency on the ground in San Diego, in Los Angeles, in San Jose, in San Francisco, and Oakland, which is where we are, and then 2 smaller counties in the north to test the rural intervention. But we didn't have to create an infrastructure. While we are a very large state, we had solid players who could come to the table and say, we can launch in January 2018, which is when we're launching. So this, I hate this slide. Sorry, Karen, you've seen this before.
Okay.
I don't know how to get it. Sorry, hold on a second. Okay, so the magic here isn't always just the food. The magic is that complete intervention we have with our clients. It's about knowing the doctors. It's about knowing the clients. It's about teaching about nutrition. It's about giving them a crock pot if they need one because they don't have one in their SRO. And then it's also about tailoring that diet to what's going on. That's the science. So the problems we solved in California or we addressed were the disparities in health, the $35 billion a year California spends on preventable readmissions. Big number, right? They're excited to figure that out. And we were able to demonstrate a return on the investment. On a very small investment in the state of California, we'll see a 20% return in the first year. It's a revenue positive model for the state, which means a lot. So we had a lot of hearings in Sacramento. If you haven't been to Sacramento, no need to go. It's where our state capital is, and really good, hardworking people. And we testified before the Senate and the Assembly 3 or 4 dozen times about why food is important, and brought all of our clients from all over the state to do that. A real lift for us, but really important. And they heard us, and we weren't shy. We went every time they gave us a chance, we did. Sometimes they didn't, we also showed up. So what we have is the result. The result is the first statewide project for medically tailored meals addressing high utilizers in the country. We will be covering in the pilot a majority of the populations in California, so I've listed the cities that we're following, 7 counties and 6 cities. We'll be revenue positive. We will show a net return in the first year to Medi-Cal, and we are a fully funded program. With last week, I'm there every Wednesday, last week the Senate Budget Committee saying that if this works in 6 months the way we think it is, we'll grow this to $50 million in the second year. That's a lot. We can't do that. But not, as Robert said, I'll say yes and we'll figure it out. Yeah. So it's exciting for us, and it's powerful, and my grandmother would probably understand this a little bit better after this, and I'm grateful for everyone who's led this movement through this for the last 30 years. And we're proud of the value of research. We spent a lot of time. We've spent all our own money. Nobody funded this, to make sure that we can prove this very simple idea, and there's a model to it. So, I'm going to skip that slide. So the most important thing is that it has to be delicious, right? It shouldn't taste like medicine, like Karen said. It doesn't have to, and it should be respectful, and that's what we do at Open Hand and at all these agencies. So thank you very much.
And now we have a bit of time for a couple of questions. If there's any questions from the audience. Sure.
Do you have any resources that aren't counted into that revenue that make it
California is kind of a weird place. So, no, I don't think so. I think that we've tried very hard to keep it very simple and to have a very few eligibility requirements so we're not overcomplicating the participant structure. So no, I think that this is a completely replicable process. The only issue would be that slide with all the agencies. It's in states where the centers of population are centered, Boston and New York City. It's hard to have other community agencies doing the work in outlying places. But California has so many large population centers, not large to us, that we have that structure. So maybe that's a limiting factor.
So my question is, and this might not be, there's an analogy here between the issue of homelessness and the high costs of homeless individuals to the healthcare system, and to what extent that Medicaid and Medicare should be paying for housing and other supportive services. And I think the current feeling is Medicaid and Medicare can pay for the supportive services, but not for the rent per se. So can you draw out that to this population? Should Medicaid and Medicare be paying for food? And is it only for the high-cost individuals that we should be paying for food? And for poor, sick, or for sick children maybe who require supplement, food, PKU diets and things like that, they don't get support because they're not poor. So help me figure out some of these subtle distinctions about how far the healthcare system should be paying for what really society maybe should be paying for anyway.
I'm happy to jump in after.
I'm going to start, and Karen's going to clean it up. It has to be a public-private partnership, I believe. In California, we believe that, the coalition of agencies, that it is not the government's problem, and it is the community and the government's problem. And if it is just a government problem, it won't create the sustainability inside of the community to support it long term. So our commitment to the state is that we will spend all their money, but the population size, they said there would be, in the first cut of data, there were 424,000 possible participants to this study. So that we're going to do 1,000 is unconscionable. So we have to find the right mix of public and private dollars to do it.
I would just add a couple of things to that. One is I come from a state where actually the director of Medicaid did put in a waiver application to the federal government to say we have to pay for housing, and it was rejected. So I think we will see more of those sort of movements because I do believe that pilot programs, 1,000 out of, what did you say, 24,000, 44,000? 424,000 is certainly small, but if it proves to save the state money in what they are doing, it obviously will have a much bigger policy impact than it might have been. But the other thing that we say to people all the time is that food is medicine doesn't mean that everybody necessarily gets good food. But if your nutritional status is such that you are not benefiting from all of the healthcare dollars that are coming your way, isn't it foolish to not do an intervention that would make all of that much more meaningful? And so our charge through research is really to show which populations are benefiting and how they're benefiting. And what we like to say is that food is medicine is a low-cost, high-impact intervention, and to prove both sides of that, the high impact and the low cost, because then it's very hard to argue against. And I would say that for a kid with PKU, as well as I would say that for many of the adults who we're all serving. But I think there's a lot to be said and a lot to be shown that demonstrates it works. And nobody questions really, another pill or another test or another medical intervention. These often work alongside, sometimes instead of, and sometimes make those effective.
I would just add, I think Karen summed it up so beautifully, but I would just say, if you're looking at the hunger population in America and the crisis we've had for, 50 years, we've brought charity, we've brought God's work, we've brought philanthropy, but we've also brought government entitlement programs, and we still have hunger. What we're interested, I think, and then maybe this is a little crass, but is bringing capitalism to it. Capitalism in America is based on profits. We're measuring through research profits so that we can make the business argument on why you ought to do this. If you're being penalized for rehospitalization rates, if you're losing money that would otherwise, capitated payments that would otherwise go into your business's pocket, we're offering you a low-cost way to keep more of that money in your own pocket. But at the same time, we're going to feed a lot of poor, sick, hungry people who are very scared and all alone.
And I think we have time for just one more question if there's any others out there. Oh, I see one towards the back.
Thank you for the presentations. And I appreciate the idea of using the model that this is a cost savings in the medical sense. In the discussion, there's been the discussion about Medicaid, potentially Medicare, but no one's mentioned SNAP or the Supplemental Nutrition Assistance Program, what used to be called food stamps. What role could that play, if any, in the work that you all are doing? Recognizing that a number of SNAP recipients are also people with diabetes and other medical conditions that could benefit from good nutrition.
Diabetes.
I'm just thinking.
Yeah. Just one thing. We all represent programs where people are really, really sick and often can't take advantage of SNAP benefits because they can't go to the market, or there is no market in their community, or they can't, even if they got the food home, they can't cook it because they can't stand, they can't lift, they can't carry. So it's to some degree a different population, which is why we're really talking about the medically tailored home delivered meal. But I think that was in some ways the first panel that talked more about the benefits of having access to good food connected to your health care and teaching people how to shop and how to cook so they could really benefit. So I think we're just talking slightly about different groups. Pardon me? Right. Yes. Yeah. One of our colleagues in Maryland, I think, has people actually using their SNAP benefits to pay for home-delivered meals that are medically tailored for their medical situation. That's not available in all states. I think Maryland may be a pilot state for that.
And one thing that I would add, and this is really underlining a point that Congressman McGovern made earlier, which is that the amount of SNAP benefits right now is so low that it makes it very difficult to pay for a higher cost intervention here. So this is still a cost-saving intervention because we're looking at people with really high medical costs and we're going to save there. But when you're looking at the actual cost of the intervention compared to your SNAP benefit, you would go through your SNAP benefit very, very quickly too. And so a number of programs have investigated that option, but we really need to take a fundamental look at how much we're providing people for SNAP to make that a workable option.
I can add a few more words just about SNAP. There is a large body of research looking at the sort of, health benefits of SNAP and access and food security and all of that. So, but I do want to point out there was a recent study, I think Seth Berkowitz published just this last month. I saw it in JAMA Internal Medicine on cost savings, medical cost savings as a result of SNAP participation compared to income eligible controls. And so I think that's very promising. In terms of, I had another point. Just in terms of the populations who can benefit. I mean, I think one thing for us in California, there's been two things that have sometimes limited how we think about SNAP in this space. One is that there's some laws regarding double participation in SNAP and SSI. Or SSDI. I always get it mixed up whether it's SSI or SSDI. And so most people living with HIV that Project Open Hand serves, for example, are on SSI. They're excluded from accessing SNAP. Technically, the amount of the SNAP benefits is added on to their SSI benefit, but it's so small, it really, with the cost of living in San Francisco, as I'm sure you may be aware of, it really isn't very meaningful. And so so food stamps are kind of off the table for our population living with HIV. California also, many undocumented immigrants, people living with chronic diseases, accessing meals, accessing health care, can't access SNAP. And so I absolutely agree it's a very important thing to continue to improve towards population health, and there's going to continue to need to be other solutions to kind of shore that up to make sure everyone can benefit.
I would just add two quick things. One is that not all of our programs provide 21 meals a week. Ours is 10 meals a week plus snacks. So SNAP is still really important in the household if you can access it for breakfast, for other meals, for feeding your families. And the other point that we haven't made today is that none of us are saying medically tailored meals should go to someone forever. It's as long as you're too sick to care for yourself and you're not able to prepare your own meals. So that could be forever if that was cost effective to keep you out of a nursing home. But it could also be 2 weeks end of life. It could be, in our case, it averages 9 to 12 months a year across our entire population.
Hi, everyone. I'm Jean Terranova, Director of Food and Health Policy at Community Servings. And it's my pleasure and delight to introduce our keynote speaker, Kevin Cranston. Kevin is Assistant Commissioner of the Massachusetts Department of Public Health, which is Community Servings, one of Community Servings' longest funders and closest partners. Kevin also serves as Director of the Department of Public Health's Bureau of Infectious Disease. As you'll see from his bio in the program, Kevin has an impressive history of service to individuals living with HIV and AIDS within Massachusetts and across the globe. Kevin was an early adopter and advocate of food as medicine and serves as co-PI in our research project funded by the Robert Wood Johnson Foundation. Kevin graciously offered to take on this role when a rule change would have made it impossible for a non-governmental entity to gain access to the data we need for this project. Thanks to Kevin, we are now able to move forward with this important work. Right? Community Servings has partnered with the Department of Public Health for more than 20 years to provide medically tailored home-delivered meals to individuals with HIV. Kevin and other pioneers in the HIV policy arena have long understood that nutrition is medicine. It is incredibly exciting that Kevin also shares in our commitment to develop the evidence base to ensure that medically tailored nutrition is provided not only to individuals coping with HIV, but also to those battling other life-threatening illnesses like cancer, diabetes, and heart disease. Thank you, Kevin, for your partnership and for your innovative approach to improving public health.
Thanks so much, Jean. That's very, very sweet of you. I appreciate it. How's my volume in the back? I usually get louder as it goes forward. And I'm going to let you look at that delicious soup. We've been looking at food pictures all the whole time. They're absolutely gorgeous, practically food porn. And so you're stuck also. You can look at the soup, you can look at me, or you can look at your devices, because I will not have slides. I want to thank Harvard Law School Center for Health Law and Policy Innovation, Community Servings, Robert, David, Jean, Katie, and frankly, all of you for your interest in this really important issue. Thank you for coming, and thank you for staying, and congratulations to Congressman McGovern. I want to thank my mom because she's been very present in my mind, my late mom. She's been gone 18 years, but she's louder than ever, and any of you who have lost an influential parent know what that feels like. The word, my mom's words, I keep ringing in my ear, and it was an admonition and a lesson, and it was, mealtime is sacred. And she meant that you better be in your chair, you better be quiet until mom and dad finish talking. We always ate together. We always ate at a set table. And the sacredness was not just what was on the plate. It wasn't just the time and effort and love that went into preparing the meal. It was being together to eat and everything that meant as a family and as a community, that food evokes so deeply in our lives that I have really appreciated in the long work that I've been able to do with community servings, that those values have permeated the work of community servings in every single meal, every single individual who gets involved in preparing those meals and delivering those meals. It is not just a nutrition program. It's a sacred program. My greetings from Commissioner Ryle, who unfortunately wanted to be here today and just was unable to make it work in her schedule. But we were both talking about 20 years ago, and it's been 20 years since the Department of Public Health and Community Servings established its formal relationship. It's also about 20 years ago that the first highly active retroviral therapies for HIV became available, and it was a transformational time for people living with HIV, that folks who were on the verge of death were able to get up and live, and folks newly diagnosed or more recently diagnosed with HIV could imagine a lifespan that was relatively normal and healthy. As I think about it, 20 years ago, the Ryan White Care Act was only about 7 years old. It was named after a brave young man named Ryan White, who had died shortly before Congress passed and the first President Bush signed it into law. He was the victim of intense hatred and bigotry in his hometown, found a new home that loved and supported him. And despite that time of stigma, which is not entirely gone, but actually hard to remember how intense it was at that time, was one of the first publicly identified persons living with AIDS in the United States and put his own image, name, voice out there. And this typifies the work that we have done through and with the Ryan White program. I think about things like Social Security, Medicaid, Medicare, CHIP, SNAP, I did have it in my notes, the WIC program, which we haven't mentioned yet tonight. It's hard to imagine American culture and American healthcare and American life without these programs. And yet each one of them had to fight their way into the governmental mentality to find their legislative and funding basis. I'd like to believe the Affordable Care Act is almost at that point where it's so baked into the American psyche, almost there, that we can't imagine living without it. And the Ryan White program can somewhat feel like that. It's hard to imagine a time fighting the HIV epidemic before the Ryan White Care Act. I remember, I'm old enough to remember, there was only state money, if there was any money at all, to support people with HIV and AIDS, other than their Medicaid or Medicare eligibility. There was huge geographic disparities in what care you could receive. And people routinely either went without or had to find their way across state lines to find the care that they needed. And that access was dependent either on their or their family or their friends' personal wealth, influence, local advocacy, and the vagaries of Medicaid eligibility. I came of age in Massachusetts. I've lived in Massachusetts for about 41 years, and so I've taken for granted what we've been able to create here. And many of the things that were in place before Ryan White were modeled on states like California, like New York, like Massachusetts, that started the invention process, and then it got baked into national law. The Ryan White Care Act was the product, shockingly, of a bipartisan agreement. Hard to imagine in the current environment. Our own Senator Edward Kennedy and Utah's Orrin Hatch worked side by side to make this program happen in the Senate, and a broad coalition in the House of Representatives made this happen. It happened in large measure because people with HIV stood up and demanded it. Folks who were actively stigmatized in their own lives took the risk to put their own names and faces and voices out there and demanded the services. It created a care system. The language in the program is a holistic system of care across medicine, public health, social work, housing, transportation, peer supports. Not only was it a coalition across those disciplines, but the CARE Act enabled us to purchase services across those disciplines and put them together. Because HIV was not just an infectious illness. It first and foremost is a viral infection, but it is a product and influenced by the very social conditions, the identities that people live with, the poverty they came from, the racial ethnic communities they came from, the countries they were born in. And all that was carried with the epidemic. The Ryan White Care Act allowed us to think about who people are in totality and purchase and influence the services that they need in order to live well and live as well as possible, but as the medicine evolved. And it took a long time for the medicine to evolve. The Ryan White Care Act and the HIV movement transformed the very power of relationships across those disciplines. The ways in which people sat in their doctor's offices or stood in their doctor's office, often between the doctor and the door, so that you could get all your questions answered and so nobody could bolt on you. The reality is we started to make choices about who we got care from and under what conditions we received that care. It was the very structure of the Ryan White Care Act. I won't go into a lot of wonky detail, even though that's what I love the most, about the parts. Just really quickly, the cities get Part A, the states get Part B, including the AIDS Drug Assistance Program dollars. Community health centers and hospitals get Part C for direct medical care. And then there were some specialized programs, D through F and no E. We always find there's no E for some reason. For specialized programs about women, infants, children, dental programs, et cetera. It was a remarkable piece of legislation that has been reauthorized and improved upon over the course of years. But fundamentally, it put at the center of the development of those systems people living with HIV and AIDS, who are not only mandated, but actually given a share of the power about decision-making, about how dollars are spent, about how services are allocated, and about the quality and feedback loop to those services. So those of us in government, those of us in medicine and other disciplines are, whether we want to or not, compelled to listen to people living with HIV and are continually in a feedback loop from the folks most in need of the services. It was a decade, 1997 was a decade after AZT. And AZT was the first moderately effective anti-HIV medication, but it wasn't very effective. It had tough side effects. It didn't really fight the virus very effectively, but it bought some people some time. A whole series of other medications bought people some time over the course of those 10 years. But in 1997, the new concept, which was highly active antiretroviral therapy or combination therapy, plus some new classes of drugs, so you're hitting the virus from multiple points of view, was a transformational medical moment. And we're in the post-HAART era, and we've been able to gain the benefits of that ever since, such that people with HIV diagnosed today have every reasonable expectation of a normal lifespan and a healthy life. Unfortunately, back then, it was hideously labeled a cocktail. There's a cocktail no one would ever drink twice. It enabled folks with HIV to live again, but it was a very, very complex regimen at those early days. And so this is the moment where the Department of Public Health began to invest in community servings as an HIV service program. The problem with the cocktail, if you will, is that it was multiple medications, a very high pill burden. This one had to be taken on an empty stomach. This one had to be taken an hour before you ate. This one had to be taken 2 hours after you ate. This one in the morning, this one noontime, this one in the afternoon. And folks found it very, very difficult, not only to keep up with just that complexity, but to time their eating in a way that enabled them to get the maximum benefit out of these drugs without losing their dose, to put a fine point on it, or not to be able to absorb it appropriately and gain the full benefit of it. Many folks were really, really sick at that moment. They'd been living with HIV for a long time. Many were already severely wasted. So they didn't just need well-timed meals. They needed meals that met their specific nutritional needs, tied to this epidemic, tied to this viral infection, and tied to the regimens that they were aiming to struggle with, because many of them had been doing this for months and for years. Since the early 90s, community servings was already out there. And community serving started as a volunteer program amongst a coalition of activists, faith-based organizations in the city of Boston, in a couple of neighborhoods in Boston, and had already demonstrated their ability to pull it together for people living with HIV and AIDS. It was a natural for the Department of Public Health, perhaps 7 years late in the system, to pick up on that work and to invest. And the reason we could invest, we didn't have a funding stream that allowed us to do this. It was the Ryan White Care Act that enabled us to do this work. The very specific issues of being able to invest in housing supports, transportation, food, and peer supports beyond the medical care, beyond the case management, really was what enabled us to do this work, and it enabled us to be partners in the growth of community servings. The intersection of these effective medicines and the challenge of eating through and around them to achieve clinical benefit meant a whole new relationship with public health. And in writing that first contract, and our partnership with David and his colleagues at Community Servings has been a fruitful one, and we're very pleased to, just in the last month, be able to announce that we've been able to continue that funding. So why would a public health program include food, though, as a critical component? I'm flashing forward at this point to some of the foundational work that Commissioner Burrell is putting forward. Her house of DPH, if you've ever seen her talk about it, there's a lot of elements, but there's three big pillars in the middle, the 3 Ds: data, disparities, and determinants. So how do the data demonstrate both need and opportunity? And I think you've had ample opportunity to get your appetite whetted, and frankly, some of your appetite satisfied, that the data are rolling in. All right, our ability to do this work depends on the quality of and the depth of the data systems that we were able to put in place. I was trained very early on by Dr. Trish Case, who is a Harvard-educated researcher, one of the founding participants in the San Francisco Prevention Point Needle Exchange Program, long before it was legal. And she used to do a speech and make us repeat after, I won't make you repeat, repeat after me, data drive policy. Data drive policy. Without the data in hand, of sufficient quality, the question is, we heard earlier, why do you have to prove, I think it's your grandmother, why do you have to prove what everybody already knows? Because no one will fund it otherwise, is the obvious answer, right? How do we demonstrate our effectiveness and be able to pull that together? It's interesting, I was on the bus on the way over here, and I was happened to be sitting with Dr. Sean Palfrey. He's a pediatrician at Boston Medical Center. He's also a master here at Harvard College. And he said, what are you talking about? And I said, no, food is medicine. That's all I had to say. Food is medicine. And he said, oh yeah, I've been talking about that lately, about how maternal nutrition and malnutrition can be a factor in infant failure to thrive. I'm like, let's get him on the next panel, okay? I mean, the Women, Infant, and Children program is public health. It has always been in public health. It's been a public health program from the start, and we're proud to be a major sponsor of a long-term federal program to support both parenting women and their newborns. Health disparities. HIV has always been typified and has exacerbated or has illuminated the health disparities in our country. And as you've heard in the programs today, similarly is true for other folks facing food insecurity. The commitment of Commissioner Burrell is not the sort of pablum of we want to reduce or address health disparities. Her goal is to eliminate health disparities. And I don't believe we can do that unless folks are well fed. I realize our time is tight, so I'm gonna kick it up a little bit. Social determinants of health has been a theme that's run through this entire presentation. We are in public health always focused on primary prevention, and real primary prevention for food insecurity and the challenges of insufficient nutrition mean we need to go way upstream and be addressing not only the economic challenges of life, but the built environment, differences in education and income, impacts of racial and ethnic discrimination and injustice, the role of unjust and differential environments that expose people to environmental stressors, stressors associated with discriminatory attitudes and systems, unequal access to health care, geographic disparities in care, in transportation, the challenges of language, migration, incarceration, and trauma, just to name a few. Our work in public health is about doing what we more or less successfully have done in HIV because of the extraordinary resources of the Ryan White Care Act, and to build on that model, to build that into the healthcare system, build it into our strategies for going upstream, preventing food insecurity, and then, of course, addressing it when we discover it. So why do we spend any of the Ryan White money on food programs today? Why in the era of relatively non-toxic, relatively simple one-a-day therapies are delivered meals still necessary for people with HIV? Not everyone benefits from these regimens. Many of them have burned through multiple classes of drugs. We have many, many folks in Massachusetts over the age of 50, 60, 70 living with HIV, who have been living with HIV for decades. And their challenges are really more looking like the older challenges of living with HIV. We know that people with HIV have a number of, for long-term survivors of HIV, have a number of challenges that are different than people newly diagnosed. Many are still struggling with wasting. Many are still having difficult food-drug interactions and are in need of acute nutritional supports. And of course, HIV doesn't exist in isolation. Many are living with concurrent chronic and infectious conditions and are seeing some of the compounded issues of aging that seem to be accelerated with long-term survivors of HIV, such as high blood lipid levels, osteoporosis, accelerated cardiovascular disease, liver disease, and dementia, all of which can create acute and long-term need for nutritional supports. But we really need to go past HIV in this conversation, and I think it's really clear to me, and the leadership that David has shown. He called me back about 10 years ago when the rest of the HIV community was essentially hunkering down and holding on to their HIV focus. Right? And that's not so much a criticism, but an observation. David was really the first in the field to look out and beyond the HIV realm. He called me up, just as he would, and said, I'm thinking about expanding geographically, and I'm thinking about expanding to people with other chronic and disabling conditions. I have this great facility, I have unused capacity, and I want to use it in a new way. And even though I wasn't in a position to fund that expansion, he still asked my permission to do so. It was a funny conversation. I think I said, yeah, at the moment. I was very excited about it. And this was a real opportunity to take what we had learned in the Ryan White Care Act, what we had learned in the HIV field, and expand it to a larger number of folks. We said for years the model we had created in HIV should be the model for healthcare and support services for all people with chronic and disabling conditions. And we have still yet to make that happen, though I'm excited about healthcare reform, and I'm really excited by the food is medicine movement. As we are trying to make the case for coverage and payment of medically and culturally tailored nutrition, I really want to acknowledge some of the work that has happened because of the ACA. The dually eligible eligible demonstration project. We're proud in Massachusetts to have one of those. We're very proud to have programs like the Commonwealth Care Alliance and their work with AARP to perform an evaluation. I was delighted when David told me they had written his first contract with CCA. So folks with a larger range of disabling conditions getting access to the services and benefits of culturally tailored and medically tailored meals that people with HIV had been enjoying for years. So I come back to the question, you know, food is medicine, certainly, but is it public health? And I assert yes. I think it asserts the life-affirming qualities of the right meal at the right time, delivered in a loving and attentive fashion, to optimize health, help sick individuals gain the benefit of medical care, to stay in their communities, to stay in their homes, to live their lives as they choose, which are lessons that I learned from HIV, lessons I learned from the Ryan-White Care Act, lessons I learned from community servings, from Robert and David and their colleagues, and from my mom. I don't need to be convinced, but it's time to prove it so that everyone else is. Happy Halloween.
Thank you all for sticking with us. I'm not going to stand between us and snacks out the door. Clearly, lots of takeaways. If you're interested, please try to get involved in the state plan, as again, we become the first state to have a comprehensive plan on food as medicine. And join us again next year. Thanks.